There's no magic line between normal and abnormal. We think about impairment and mental illness when it reaches the point where it's impacting a person's quality of life. So, for example, we all have worries. We all have at times experienced feelings of panic that things aren't going to go well or that something bad's about to happen. But when that feeling becomes so pervasive that it keeps us from engaging in our community or leaving our house or doing the kinds of things that we want to do, when the symptoms reach that level, that's when we would say we've crossed into a disorder, and we should really start thinking about the types of medication and therapy treatments that would be helpful to that condition. DSM as we know it now really began in the 1950s when the APA released a number of specific disorders with criteria as to how we might define and categorize those disorders. The DSM is designed to have flexibility within each diagnosis. It doesn't require that two patients with the same disorder have exactly the same presentation. So for example, in the disorder OCD, obsessive compulsive disorder, patients have both obsessions and compulsions and functional impairment. But those obsessions and compulsions may not be the same from patient to patient. So you might have a child who's afraid of germs and who's compulsively washing his hands for hours a day, and we would call that OCD. And you might have another gentleman who is afraid that he's run over a person with his car and is spending hours a day circling the block or walking from his office back to the parking garage to make sure that there aren't feet sticking out from underneath his car. For one patient who may have depression that's largely characterized by low energy and inability to get out of bed and feeling numb, another person might feel jittery, have low appetite, and feel sad. Both folks have depression. Both respond to treatment, but they have individually very different presentations, even though they have shared the same common diagnosis of depression. Having a common language and a common framework allows us to advance the field. That is to say, in having a shared understanding, we can ask deeper research questions around what is causing these disorders. It allows us now to look at things like how genetics might be influencing our expression of mental illness, because now geneticists and psychiatrists can be sure that we're talking about the same kind of common languages when we look across tens of thousands or hundreds of thousands of patients. It really provides the foundation through which we start to look at many of these research questions around what is the underlying cause of mental illness, but also importantly, what is the treatment that's going to help patients with these illnesses.